Okay.
Yes, sir. Full screen, please, sir.
Yeah.
Yeah.
Okay. So I'm going to be talking about injuries around the hip in children. So to give you an overview about what we are going to be discussing, so I'm going to be talking about the limping child, as this is probably one of the commonest presentations that a child presents to, and that's usually around problem around the hip. We'll talk about common acute hip presentations, assessment and management of these problems. This has been discussed in a separate section, some of it in the pediatric elective side, so I'll not go into detail, but more as an algorithm as to how to go about assessing. And then we'll talk about high energy trauma, which is fractures around the pelvis and the proximal femur. So traumatic hip injuries are very uncommon. It's a rare sighting unless and until somebody is in a major polytrauma setting. But most of us will see often children presenting with painful hip. So let's start with that. So first we talk about the limping child. The history may be unclear, especially in young children, infants, where they may not be compliant, the examination is difficult, and the history of trauma may not be clear or may not be present at all. So let's talk about the hip. The reason you see the knee X-ray there is because it is not uncommon that a child may present limping and pointing to the knee with pain. So think about the hip. It could, and it is more likely to be, a problem with the hip rather than the knee, as we can see in this case. So limping child, the first thing that you'd want to rule out is septic arthritis. Affects all age group children, higher incidence in less than 2-year-olds. If they are more than 2 years old, the commonest organism, again, is Staphylococcus aureus, as in adults. And the presentation is usually, there may be a recent history of trauma or infections, an earache or a sore throat, acute onset of pain. Child is reluctant to put weight on one leg, and the leg may be in attitude of flexion, abduction, and external rotation, as that is the most comfortable position for the hip to be in, given that that's where the joint capsule has the largest volume space. So in terms of investigation or how to go about investigating this child when they arrive, so after a succinct history, ensuring that there's no non-accidental injury associated either. Blood tests would be indicated, a temperature check, X-ray of the pelvis, AP and frog lateral. Ultrasounds can be helpful in these situations, and consider scanning both the sides to be able to assess whether there is an abnormal effusion in one hip or not. MRI has a better diagnostic value, as it is also able to assess the bones on the acetabular side as well as the femoral side and rule out osteomyelitis. It is good, especially if the presentation is long-term. But if you're convinced about septic arthritis, do not waste time waiting for an MRI scan. So Kocher criteria is the important criteria to assess for infection. A child who's not weight-bearing because of pain has got a temperature of more than 38.5 degrees centigrade, has a CRP of more than 2. In UK, we use more than 5. White cell count of more than 12,000, has got a 99% probability of having septic arthritis. So in management, again, low threshold for urgent surgical intervention. A general anesthetic and a hip aspiration may be useful in this situation. If there is pus, open the hip and wash out. Prolonged treatment with antibiotics is indicated. different countries and different hospitals have got different choice of antibiotics and the duration, but normally it is about 4 to 6 weeks, partly IV and then partly oral. The second differential diagnosis could be DDH. Again, children who will be present are likely to be less than 2 years old. They would be limping. Usually it is picked up by the parents when the child starts walking, and then they see that the child is limping or reluctant to put weight on one side. The thigh creases may be abnormal. And the risks factors for DDH would be firstborn, breech presentation, a family history of DDH, and other packaging disorders such as metatarsus adductus or tibial torsion. Barlow and Ottolini's test by that time may not be relevant. However, what is relevant in this situation would be to do the Gagliardi test to assess for a leg length discrepancy, primarily on the femoral side. Again, investigations, if the infant is less than 6 months old, then an ultrasound scan. But for a child beyond 6 months of age, an X-ray will be a better modality. Again, the management has been discussed elsewhere in detail, but the mainstays for younger children, harness and abduction spica. And if the presentation is delayed, then surgical interventions are more likely. Next condition could be Legg-Calve-Perthes disease, which is idiopathic avascular necrosis of the femoral head or the proximal femoral epiphysis. Incidence is about 1 in 10,000. Commonest age group presentation is a limping child between 4 to 8 years of age. Commoner in males, and other risk factors are, again, family history, low birth weight, abnormal presentation at the time of birth, history of smoking in the parents, which is indirect smoke inhalation, and also certain ethnicities. If the age at presentation is less than 6 years, then it is usually associated with good prognosis. The imaging of choice in this situation would be X-rays, which may show an abnormality in the epiphysis, or more usual finding may be a high index of suspicion, where the epiphysis on one side appears different to the epiphysis on the other side. In that case, if you're concerned, arrange an MRI scan, because that will tell the real picture. Again, the management is primarily conservative. The prognosis is usually good. In most situations, it resolves. The mainstay of the treatment is to contain the head, either just by observation or by surgical intervention, especially if the problem persists beyond 8 years of age. The other condition that is absolutely critical to investigate and diagnose and make sure you don't miss is SUFE or slipped capital femoral epiphysis, especially in young teenagers or adolescents. It is the most common disorder affecting adolescent hip. Incidence is about 1 in 10,000. It may present as a traumatic injury. There may be history that the adolescent might be playing football when they experience sharp pain in the groin or the knee and have not been able to weight bear since. Common age groups is a child limping between the age group of 10 to 16. Important risk factors to bear in mind are obesity, males, and rapid pubertal growth phase, which is again in that age group of 10 to 16. There are various classifications. One of them is loader, which is essentially assessing stability in terms of weight bearing. So if the child is able to weight bear either with crutches, then it is likely to be a stable slip. But if they are not, then it is unstable. So be cautious. Investigations, again, X-rays. Different classifications and the diagnostic modalities have been discussed elsewhere. The mainstay of the treatment in this situation is early identification. So don't miss out on that young teenager complaining of knee pain. Surgery will be in situ pinning. Single screw is good. And think about endocrine disorders. And if you're thinking about endocrine disorders, think about pinning the contralateral side before that slips too. Now, having discussed the limping child or non-traumatic or low energy injuries, let's move on to high energy injuries around the hip. Let's talk about pelvic fractures first. They are uncommon. About 1% of all the pediatric fractures that you might see might be a pelvic fracture. They are generally pedestrian versus motor vehicle. They can be ring fractures, wing fractures, which is the iliac wing, acetabular fractures, and then avulsion fractures, or the epiphyseal injuries around the pelvis, and these are the low injury category. Pelvic ring fractures, unlike adults, there is a higher incidence of lateral compression fracture in children. And the reason for that is the bone elasticity. Thick periosteum, cartilage absorbs energy more efficiently, and the joints are also more elastic. And the other reason for lateral compression is that generally it is the pedestrian running across the road being hit by the car from the side. Talking about avulsion fractures, they are due to pull of the muscles attached. Ischial tuberosity avulsion fractures because of pull on the hamstrings and the adductors. Anterior inferior iliac spine avulsion fracture, as we see in this X-rays, is associated with sartorius pull. Again, these are running and sport related injuries, usually in young teenagers, children in the age group of 10 to 16. Again, pubic symphysis may have avulsion because of abdominal muscle pull. Iliac crest, again, abdominal muscles, and iliopsoas, which is attached to the lesser trochanter. Now, let's talk about the osteology around the pelvis. Sorry for the busy slide, but as you can see, it is slightly complicated. There are lots of ossification centers, but in a nutshell, 3 main primary ossification centers, which appear within the first 20 weeks, and all of them fuse together around the time of puberty. And the ossification centers are essentially the 3 major parts of the bone: ilium, ischium, and the pubis. Acetabular growth is particularly important in this age group. It happens through interstitial growth in the triradiate cartilage. There are 3 secondary ossification centers which form the superior wall, the posterior inferior wall, and the anterior inferior wall. These ossification centers appear around the age of 8 and fuse by the age of 18. There are multiple other secondary ossification centers in the pelvis, which are essentially related to the epiphysis that we previously discussed. Important one is the iliac crest, which appears at the age of 13 to 15 and fuses by the age of 15 to 17. This ossification center is particularly important because there's a classification called the Risser classification, which is used to assess the remaining growth and the impact, especially used by spinal surgeons to assess whether a scoliosis or a spinal deformity is likely to worsen or not. Okay, talking about pelvic fractures, there are multiple classifications. I'm going to discuss two here. The first one is tile classification, which is essentially to assess whether the fracture is stable or unstable. And type A is, which is stable both rotationally and vertically. Because in children, it is not an uncommon finding with the pelvic ring fractures that only one bone is fractured and the fracture is not progressing across to the other side of the ring. So it is more likely to be a stable injury. Type B is, which is stable vertically. So these are the open book kind of injuries. And type C are unstable rotationally as well as vertically. So they are, it's opening up as well as it is unstable in the vertical plane. The other classification is Torod classification, which is essentially to do with the location of the fracture and also a component of stability. So type 1s are avulsion injuries, type 2 are iliac wing fractures, 3 are stable ring fractures, and 4 are unstable ring fractures. So fairly simple and easy. Talking about management of pelvic fractures, again, ATLS protocol is important. These are high energy injuries. There may be other more life-threatening injuries around the head, chest, spine, or the abdomen. Even in children, pelvic, although lateral compression injuries are more common, pelvic binder is still advocated and is a part of the pediatric trauma protocol because that is primarily to do with reducing the hemorrhage while the child is being transferred from the site of the accident to the hospital. So have low index of suspicion of pelvic injuries with high energy mechanism and have a low threshold for putting on a pelvic binder. A simple sheet kind of a pelvic binder is sufficient, and it should go at the level of the greater trochanterus rather than the iliac wings. Again, bruising may give you an idea that there could be a possible pelvic injury. Make sure to rule out non-accidental causes of the injury. X-rays may not reveal an injury in 50% of the cases. Therefore, CT scan is the gold standard and should routinely be performed as a part of the trauma series from the chest down to the pelvis, and may or may not include the head and the neck. MRIs are more relevant for assessing the injury subsequently after the initial management has been carried out, or if it is more likely to be a low energy sports injury, such as an apophyseal avulsion injury, which may not be apparent on the x-rays, but would become clear on the MRI scan. So if a child presents with an injury that you suspect could be related to a muscle strain, if it is not settling down, think about an MRI scan. Again, management is either conservative or surgical. In the conservative management, if there's less than 2 centimeter displacement of avulsion injuries, these can be managed with protected weight bearing and return to sports in 8 weeks. Less than 2 centimeter displacement wing injuries, protected weight bearing, and then again return to sports in 8 weeks. Ring fractures without instability can be managed by weight bearing as the child is able. Minimally displaced acetabular fractures, again, a close follow-up is crucial. Touch weight bearing is probably better than non-weight bearing because it does reduce joint reaction forces and also gives them second stable leg to balance themselves. Unstable ring fractures, if they are less than 2 centimeters, can be managed non-weight bearing with bed rest. Surgical management, again, the open reduction internal technique, again, the approaches can be stopa or iliofemoral, depending upon what the CT scan shows once the surgery is being planned. But what is different in children is that one should consider smooth pins instead of screws and plates. And if screws and plates is being put in, then consider early removal at 6 weeks. Grossly displaced avulsion fracture, especially in performing athletes or aspiring athletic children, should be considered. But again, it is important to discuss the surgical risk, such as soft tissue injury, the extent of the scar, with the child and the parents to ensure that it is a measured and a valid surgical intervention for the child. Grossly displaced ring fractures with displaced acetabular fractures is an indication for surgery. Unstable displaced fractures, and then external fixator, again, can be used as a damage control procedure to attain hemodynamic stability while a laparotomy is being performed or is being planned by the surgeons as a part of the initial trauma management, but may be considered as a definitive management as well, because in 4 weeks' time, as the healing is much quicker in children, these can be removed. Again, talking about complications of these injuries, physeal cartilage injury is one. Premature closure of the triradiate, apologies for the typo, especially if the children are less than 10 years of age, there is a high risk of secondary deformity to the acetabulum as a result of premature closure of the triradiate cartilage. Therefore, keeping a close eye is important. Leg length discrepancy can occur. Malunion, non-union, nerve injury. Either it can be primarily as a result of the injury, especially if it is involving the sacroiliac joint, or it can be secondarily as a result of a surgical intervention. Heterotropic ossification, avascular necrosis of the head, and also osteoarthritis as a long-term sequelae of injuries which are involving the acetabulum. Talking next about traumatic hip dislocation. Again, it's a high energy injury, usually associated with road traffic accidents. Low energy injuries can happen in children less than 10 years of age with sports. 80% of these dislocations in children are posterior, more common than hip fractures. There is a high risk of AVN, therefore they have to be treated as surgical emergency and reduced within 6 hours to prevent excessive risk of AVN. The children may present with leg in slight flexion, adduction, and internal rotation as the head is hooked under the posterior aspect of the acetabulum. There may be a leg length discrepancy, and the child may have a foot drop because of pressure on the sciatic nerve. Again, investigations of choice. The first modality would be a plain radiograph, AP and lateral view of the pelvis. It is also important to get another X-ray done post-reduction to assess for joint congruity. In that case, do look for incongruity of the joint, especially compared to the other side. because that will indicate that there may be an incarcerated intra-articular fragment or an osteochondral fragment. In that case, MRI scan or a CT scan would be indicated to assess the injury further. Closed reduction under general anesthetic preferably is indicated at the earliest. There are studies which show that the risk of AVN goes higher if the reduction is performed more than 6 hours after the initial injury. Before the reduction, it is important to assess for neck fractures. And therefore, it is important to reduce these fractures under X-ray or image intensifier control in the theater to ensure that there is no physial or neck fracture. The reduction is performed by traction with a knee flexed and gentle rotation maneuver. Once the joint has been reduced, test for stability. And if it's a child below 10 years of age, do consider putting the child in a spica, especially if they are very young, for about 4 weeks. Open reduction, again, the approach should be in the direction of the dislocation. Posterior is the commoner dislocation, so therefore posterior approach is more likely approach that one would have to take. The indications for open reduction would be non-concentric reduction, identified on the X-rays and the CT scan, intra-articular fragments which need to be reduced or removed, and also unstable rim fractures, which are making the hip dislocatable on initial assessment after reduction. And also if one is unable to reduce closed. Then complications, there's an AVN risk of 3 to 5%. Children who have had dislocation of the hip may show coxa magna as they grow and in adulthood, but it is not associated with any grave consequences by itself. There's also a risk of redislocation, especially if there are associated rim fractures, and also a risk of sciatic nerve injury, but more often than not, the sciatic nerve injury will resolve after the reduction. Now talking about proximal femur fractures, again, rare fractures, they are, again, a high energy injury, but they may also be associated with low energy, especially if there is an underlying metabolic bone disease or tumor. And also especially if you see these fractures in non-walking age group or below 4 years, then it is important to rule out non-accidental injury. Again, the classification for these fractures is Delbert classification. Type 1 is transphysial, which happens across the growth plate, and understandably it has the highest risk of avascular necrosis. Type 2 is the commonest type, which is transcervical. Type 3 is basicervical, which is associated with highest risk of non-union. And type 4 is essentially intertrochanteric, the best blood supply, and therefore the best outcome. Again, in investigations, X-rays, AP, and in this case, like we do for an adult neck or femur fracture, a cross-table lateral will be helpful. But if the fracture is visible on the AP, then there's not much relevant point of subjecting the child to pain with a cross-lateral. However, if you're suspecting a fracture with the mechanism and the presentation, but the X-rays are not showing any clear fractures. CT scan could be performed in centers where there's no MRI. However, MRI is a better diagnostic modality, especially to rule out undisplaced fracture, as the thickness of the slices is much less as compared to a trauma CT scan, which may be about 2 millimeters and therefore may miss undisplaced fractures. And further MRI scan will also be helpful to identify pathological fractures. Again, in management, conservative with close reduction and spica is rarely indicated. The mainstay of the treatment is surgical in these cases, because with close reduction and no fixation, there remains a risk that the fracture could displace, and then it might require a delayed surgical intervention with a worse outcome. Therefore, it is more likely that if we are reducing it or stabilizing it, we should pin it. The close reduction and percutaneous fixation is useful in type 1 to type 3. Depending upon the age of the child, one can either use pins, especially if it's a child less than 4 years, or cannulated screws in older age group children. Close reduction can again be performed with certain maneuvers, which is gentle traction, abduction, and internal rotation. And that should reduce the fracture. However, if the fracture fails to reduce with close technique or are unable to achieve a near anatomical reduction, then an open reduction may be indicated. For type 4 fractures, a sliding hip screw and a plate fixation, just like a DHS in an adult intertrochanteric fracture, may be of benefit. Again, to supplement the pinning, in a younger child, consider spica casting to add further stabilization. And also, in all age groups, it is important to consider early removal of metalwork, and also one should take care not to cross the physis if one can avoid it, especially in type 2, 3s, and 4s. And if one needs to cross the physis, then single smooth screw or pin may be a better option. Talking about complications again, the big risk is avascular necrosis. With type 3 fractures, there's a risk of coxa vara, where the neck shaft angle may be less than 120 degrees. Coxa valga can also happen, especially with injuries around the trochanter and early fusion of the GT epiphysis, non-unions, leg length discrepancy, and also a risk of chondrolysis, especially with metalwork being put in to stabilize the fracture. So please do take care not to breach the cartilage. Thank you. That'll be all from my side.
Thank you so much, Mr. Amit Vats, for this very interesting and very valuable presentation. Thank you so much, sir.
Pleasure. Thank you.
We are ready to receive questions to Mr. Vats. The first question will be from me, sir. In a very young age, about maybe 4 or 5 years, what's the best option for treating AVN in post-traumatic cases?
So again, AVN, again, one will have to assess whether it is partial or complete AVN. So essentially, how much of the head it is
Yeah.
involving. One way of further, so firstly, prevention. So if we talk about prevention, firstly, if one is suspecting that this particular case may have a higher risk of AVN, then decompressing the capsule may be one option. And subsequently, a core decompression is one option. In children less than 4 to 5 years or so, children less than 5 years of age, the prognosis is very good because it is almost like Perthes, and usually it will resolve.
Yeah.
So one would hope that with the healing, the injury should heal without any surgical intervention. So observation is primarily the main treatment. So core decompression does leave a risk of physial damage. Yeah. So that's one consideration. So in most cases, below 5 years of age, observation is the mainstay of the treatment because one would assume that, like Perthes, avascular necrosis would have a certain potential to heal, especially if it is partial.
Yeah. Do you think, sir, there is a rule for post-traumatic, in case post-traumatic AVN, is there a rule for chondrodysplasia or external fixator, such like in Perthes disease, or it doesn't have a rule?
You mean osteotomies you're talking about, or?
No, by external fixator, and I mean chondrodysplasia. Does it have a rule in post-traumatic cases?
So I do not have any personal experience of it, of course. It's a very, very rare condition. The literature is quite controversial in this situation. And most of the evidence that we see is, again, case reports and small case series. It's a very specific problem. My personal feeling in the matter is to treat it like Perthes and remain non-surgical, especially if the head is contained.
Yeah, thank you, sir. We have some questions from our dear attendees and audience. First question is, why is intertrochanteric fracture type 4 when it has the best prognosis?
Well, that's the classification that tells me.
It's not in my hand. Yeah.
Yes. So I suspect that was more to do with the anatomical position, and to keep it simple, they have moved from proximal to the distal.
Yeah. Yes.
So that's the only relevance that I can see in this situation. So I think it's more anatomical based.
Excellent. Another question, after which time do you prefer to remove the DHS in basal neck fracture in a child 12-year-old?
So again, within 6 months is the choice, but there's a certain amount of variability in these cases.
Yes.
So I'd leave, because it's a neck fracture, I would leave it at least for 6 months.
Yeah. Another question, what's the best treatment to treat basicervical femoral fractures in a child, screws or DHS? What's your preference, sir?
So if it is an older child, a DHS type of a method is better. Because again, in keeping with the principles, it is going to provide adequate compression at the fracture site as well. With the screws, we do not have a dynamic construct. So therefore, there is also a chance that as the fracture compresses, there is a chance that it may further progress into the physis. So not something that so if I'm considering for intertrochanterics, I would consider a DHS type of a plate because of the dynamic construct to save the physis. In younger children, especially if they are very young, less than 5 or 6, then I would go more towards pins rather than any other instrumentation. In between, pediatric sliding screw and plate construct. just like we would for a femoral osteotomy.
Yes, sir. We have 4 questions. 2 of them you have already mentioned, sir. The third question, what is the best direction for cannulated screws in type 2 and 3?
So again, it depends upon the dislocation. Most of the propensity of the fractures is to slip posterior-inferiorly, therefore anterior anterolateral cortex in the direction of posterior-medial is the best option, in my view.
Yes, sir. The last question, sir, is regarding transphysial screws or pins for patients between 6 to 12 years with displaced fracture. Is achieving fracture stability is more important than preserving the proximal femoral physis?
Sorry, repeat the first part of the question. Sorry, Professor, I didn't.
Regarding, sir, regarding the transphysial screws or pins for patients between 6 to 12 years with displaced fracture, is achieving fracture stability is more important than preserving the proximal femoral physis?
I think both are important in this situation, and both are interconnected. So by achieving one, we give the other a better option. So essentially, by achieving healing and reduction, we are giving the head a better chance to, because the problem with the blood supply is kinking, which happens with displacement. So if we reduce the fracture, then there is a better chance that the head will be viable.
Yeah. Thank you so much, sir. Finally, from the bottom of my heart, I would like to thank you, Mr. Amit Vats, for joining us tonight. And thank you for the time you spent with us. And you are, of course, very welcome to complete the presentations with us and to see your opinion regarding any of the next presentations, sir.
Sure. Thank you very much.
Thank you so much.